We should talk about what these calls do and what resources they mobilize. It takes a while to get everything ready for that patient. All the things that need to happen have to start happening. They call it parallel processing. While you're moving them to the hospital's getting ready. And no matter how good people are, if somebody walks into the door and we have no idea, either they drove in or it didn't get picked up or you weren't able to pre-notify, we've lost that time and we cannot regain that time. We can't catch back up.
I had a coworker once say to me that I worked alongside, said, lead with the punchline. What are you doing? Is this patient getting CPR? Are they being bagged? Were they shot? Where were they shot? What is bothering you? What is bothering that patient the most?
What does it really take to deliver truly patient-centered care in EMS? This is the EMS Clinical Brief, where we explore how research, clinical expertise, and patient values guide care, and how quality improvement and culture can shape what's possible. Hi, everyone. Welcome to this next episode of the EMS Clinical Brief. I'm your host, Maya Dorsett, and today we're going to be talking about hospital notification as a clinical intervention. So we think about hospital pre-notification all the time, and there's a whole bunch of variability between hospital systems and regions about who they expect pre-notification for. But today we're specifically discussing hospital pre-notification for the patients where it really, really matters that the pre-notification occurs and why it might be one of the most important clinical interventions that you provide. I am really lucky to be joined by two guests who have thought and lived this a whole bunch. And so will you go ahead and introduce yourselves? Why don't we start with Tyler?
Hey, I'm Tyler LeMay. I'm one of the EMS physicians at the University of Rochester and started 23 years ago as an EMT basic. So I've been doing pre-notification for a couple decades now.
Hey, Jen.
Hey, I'm Jen McLyman. I am a paramedic for, 10 years now. As an EMT before that. I'm not currently on the road. After my time on an ambulance, I spent a couple years in our local level 1 trauma center as a communications specialist, taking calls for trauma, strokes, STEMIs, everything. Did that for a couple years, and now I'm actually working in clinical research. So I'm out of EMS, but I still love EMS. So
And this particular topic for a podcast was Jen's idea. So she reached out to me and said, hey, I listened to other episodes of the podcast, and I think we should be talking about pre-notification because it's really important that it is done well. It impacts patients. And I think that there's valuable things that we should discuss. So if you like this topic, thank Jen because it was her idea. But I think it's definitely a unique perspective as someone who has both made the call-ins, but then literally taken every single phone call coming into the ED and thinking about what information do we need to make things happen for patients, and then specifically, why is it so important that that pre-notification occurs and how it occurs? So I'm implying that pre-notification is really important, right? I started off that way and said it's like the basic assumption. Why don't we talk about specifically what patients is pre-notification particularly important for and why? And I'm gonna pass it over to Tyler, but then Jen, I'd love you to fill in as well.
Cool. So I've spent a lot of time talking about how much care we actually bring to the patients and how important it is for us to take care of patients where we find them, and how many of our patients don't need to be rushed to the hospital because we've brought that care out to them. But there are still those exceptions where what the patient needs is at the hospital. And specifically with pre-notification, what the patient needs may not even be immediately available in the emergency department. And those are the patients we're going to talk about today. So the classic examples of, people who need to go to the operating room or the cath lab, people who need a team ready or equipment that's not in the emergency department. Those are the patients that are really going to benefit when you give us a heads up on the way into the hospital.
Yeah, so Tyler, I totally agree. When I teach paramedic students, I tell them one of the most important questions they can ask for every patient is, what does this patient need most? And when I say, what does this patient need most? It's what do they need most to improve their outcome, their longevity, their neuro intact survival. And if you frame things in terms of that question, patients kind of fall into 3 different categories. Sometimes, very often, what the patient needs most is something that you have. So if a patient is in severe respiratory distress and needs non-invasive positive pressure ventilation and a bunch of nitro for their CHF, like you have that. So giving them that is the priority before thinking about transporting to the hospital. And the ultimate example of this is a patient in cardiac arrest, where we learn we need to stay and give them the things that they need. And there's no like magic medications at the hospital for the majority of these patients that are going to make a difference in their outcome, or a patient in anaphylaxis. That's why we put Epi in the hands of mom, dad, and everybody else. And so it's what does this patient need most? I need to give that to them right now and not go anywhere. And then there's the patients where they need some things, but it's not extremitous or time sensitive. And what they need most is, they might need some, I would say, like pain management, right? And that's something that I'm going to give them, or they need a thorough assessment. And there isn't this time criticality to some of this. I mean, in some cases, pain management is time critical, but there's a lot of things where it's not super time critical. It just matters that it gets done, and the order in which it gets done is not as important. And then there's this third category where you have this patient and you say, what does this patient need most? And do I have it on my ambulance or in my gear, or can I provide it to them? And if that's a patient with an occlusion myocardial infarction, what they need most at first is me to recognize, could this be an MI? And then what they need most is for me to do an EKG. And then when I find that EKG has a STEMI, what they need most is somebody to reperfuse them. And so what I have to think about is, how do I shorten that time to intervention for those patients who what they need most is not the thing I have? And I love how you started, because what they need most is sometimes it's something the emergency department gives. Sometimes it's the mobilization of an entire other team that may not physically even be in the hospital, or maybe doing other things in the hospital. I think the classic examples are occlusion myocardial infarction, right? There is large amount of data, including one systematic review meta-analysis that said 39% reduction in mortality for having a pre-hospital EKG and a pre-notification as a bundle. Okay, there are very few things that we do that have a 39% decrease in mortality, but that is one of them. And this is a time dependent manner. So they've looked at all of this and said, okay, like if you're not calling more than 10 minutes from when you get to the hospital, you're like effectively not calling there, because you haven't given enough time for things to happen. And the longer it is from when you've called to when you get to the hospital, the shorter time it is till the patient gets that intervention. So not only is it that I did the thing, but I did the thing when I'm a certain distance out from arriving at the hospital. And that's not mileage, that's minutes. As Jen, who worked in the city, knows, a third floor walk up in the city of Rochester might have a much longer ETA than a farther out suburban agency. So stroke, there's data from multiple state registries as well as national data that it's decreased time to intervention as well as mortality for those patients. And I think that's probably, I haven't seen updated data as much since the embolectomy work is, but if I think about embolectomy for stroke is like PCI for STEMI. And then for major trauma, it's complicated because surprisingly, there isn't US North American based data. There was like this big Indian study that showed an impact on mortality. But what it does show is an impact in time to when that patient gets transfused, time to when that patient goes to the OR, time to when they get CT imaging. And all of those things we know from other work are predictive of your mortality. It's kind of complicated because, one, it's hard to measure whether or not somebody made a hospital notification for trauma, because in every system it's a little bit different. And we know from national studies that the element that says I made a pre-notify in NEMSIS is almost like never used in any way that's reliable. But the other thing is, trauma is a much more heterogeneous disease process than STEMI. And so patients who are sicker, I'm more likely to call for the dude shot in the chest than grandpa who was in a motor vehicle accident and might have a pelvic fracture. And so there's a lot messier data around trauma mortality. But that's just to say, like, these are the cases that we know. We're going to talk about other cases, but I think it's important to note, like, there is data that says, just like I give aspirin in chest pain, or I, do CPR and cardiac arrest, or I do these things because they impact mortality. Pre-notification for patients who what they need most is not something I have, has a mortality benefit in the literature and the evidence.
I remember not too long ago, a brand new paramedic gave me a call and said, I have an EKG. Monitor says it's normal. It doesn't look normal. He's gray. He's diaphoretic. He's tachy. His pressure is dropping. But everything else looks pretty normal. The EKG, I've done a bunch of them. He looks normal. We were, of course, very busy. And I was able to pull up an old EKGs of his. She was able to send me the EKG, and it was dramatically different. And I said, get in here. And I called a STEMI alert, and everybody looked at the STEMI initially. This isn't a STEMI. This is not reading STEMI. And I said, just wait till you see the patient. And he ended up coding on the way up to the cath lab. They got him back. And he walked out like 2 days later. And this paramedic was worried that she was calling when she shouldn't have called. She said, I feel bad for calling. It doesn't read STEMI, but it just doesn't feel good to me. And her gut was right. And I received that. It hit me. I had a gut feeling about it too. And the guy walked out. So go with your gut. If they're sick, they're sick. Let us know, because it can't hurt. It can only help.
And if you think about that case, right, the alternative of the not call, and in some systems, right, like people in Rochester listen to this and things might be very different in EMS system about what the expectation is to call. But in the circumstance where there isn't a call ahead, where there isn't a discussion about why there is a clinical suspicion that this is an occlusion myocardial infarction, this patient arrives in the ED. There isn't a cath lab available to evaluate him. So the emergency physician is evaluating. He's like, yeah, I agree that this guy looks like crap, right? Then they are calling the cardiologist. That's the point where the patient codes. And so other than a good clinical assessment, which is the single most important thing that any EMS clinician does to suspect what it is, if you think about the change in the patient's course of trajectory of a pre-notify versus a not pre-notify for that patient, they're potentially dramatically different with a life or death change in the outcome.
Can we talk for a minute, Maya, about, I think people have a lot of fear about being wrong. Folks, I think, are very afraid that they're going to call in and the hospital is going to be dismissive of, oh, that's not a STEMI, or this doesn't meet trauma criteria, or I think maybe in their eyes, even worse, that we activate and then deactivate. And I think it's important to know, when we interface with the cardiology team about STEMI or the trauma team about these trauma alerts, they're expecting more activations than we need, than would be perfect. Like, they all acknowledge that we're going to have to catch 2 or 3 or 4 times as many patients with these alerts to get the ones that really needed to be picked off. But they all understand that it's very hard to sort those out in real time, sometimes impossible. And so having that level of suspicion, being willing to make that call when it's close, or you think, or you're worried, is really okay. And I know that EMS clinicians don't always get that message, but I definitely want them to hear that message from us, and know that that's the message from the trauma team and the cardiology team and the neuro team. They want to hear about these patients, and they know that they're not all going to turn out to be, major hemorrhage going to the OR, or a big occlusion MI that needs a stent.
Just to kind of piggyback on what you said, Tyler, at my time at the desk, I got so many calls from amazing EMT basics who have the sharpest assessment skills, who would call, and they didn't have a 12 lead. All they had were their eyes, their ears, their hands, and vitals. And they made some really good calls, and they were nervous about doing it, but they did the right thing, and they saved a lot of patients.
I think it's about where you want the sensitivity in the system. The sensitivity should be upfront. I think about this a lot in terms of posterior circulation strokes. because one of the big barriers is, one, they're really hard to catch. As an emergency physician, I see dizziness. I'm like, oh, right? Like dizziness and hypertension. Because it's nondescript. When I'm calling a stroke neurologist about a patient, or I'm making a decision about what imaging a patient needs, or do I need to call a stroke alert, very rarely felt extraordinarily confident with posterior circulation strokes in the absence of significant cranial nerve deficits. But I do it anyway, because it's much worse for me not to catch it and then have a patient who for some reason has like a stuttering occlusion in their posterior circulation, who has a bad outcome because I didn't expedite workup for a patient with a potentially time-sensitive condition. And so I think it's important here, like, we want the sensitivity up front. And then also there's times where we get EKGs out of triage and we're like, I don't know, but the patient looks not good and their story is convincing. And even though this EKG is not a slam dunk, like, I'm going to call it, because if this were my person, that's what I would want somebody to do. And sometimes we're wrong. But then there's ones where we're right, and those patients would have had a significantly different outcome in their trajectories. People might get negative feedback. I mean, and I know that sometimes they get negative feedback, right, from people on the other end who are overworked and low bandwidth and working in low resource situations. And that doesn't excuse the negative feedback or sort of the lack of appreciation what was done. But like, we got to keep doing it because it's the right thing for the patient. So I want to talk a little bit about clinical prioritization, because I hope we've convinced people that it's important. And if you suspect that there's something time critical or something that the patient needs at the hospital, then we should definitely call. And we talked about some situations where that's true. In terms of clinical prioritization, I open this up saying pre-notification is a clinical intervention. Right? It is a treatment that I provide to a patient. So in EMS, I know this, Tyler knows this, Jen knows this, we have very limited resources on the scene. When I explain EMS to the residents, I just had new residents and I was teaching them things. I said, a paramedic needs to play the role that in the emergency department would be played by the physician, the pharmacist, the nurse, and the social worker, all at once, by themselves, right, in the back of the ambulance. So it's limited resources. So prioritization of interventions, which is important really in everything, is extra important because there's fewer resources in EMS. How do you decide when do I take the time to make the phone call or make the pre-notification as far as the order of interventions that I'm doing? And Tyler, you are shaking your head like you have an answer to this.
Yeah, I've thought a lot about this. This is my favorite challenge in pre-hospital medicine and in emergency medicine, is that you can't do it all, right? The right answer can't be, I read back the textbook chapter of everything this patient needs. The right answer is, which two things does this patient need? Because that's all I have time and bandwidth to do right now. And so we have habits in EMS of the things that we do for all these patients. And some of those habits are really like carefully cultivated to get the right things done for the patient right up front. So to Maya's point earlier, you have a patient who doesn't look well, they have chest pain or any of the anginal equivalents, right? They don't look good, they don't feel good, they're dizzy, they're short of breath, they have back or shoulder pain, something's weird, right? Like pain between here and here.
Sweaty. Oh, yep. When they're sweaty, yes.
Then you guys do the EKG, right? That is the time-dependent intervention. The IV's not, the nitro's not. Like, until we know what that EKG looks like, that is the most pressing thing. I think knowing which intervention comes next is dependent on which disease process. So, thinking about MI, to keep following that example along, that first step is to recognize that this might be one of those patients. The second step is to get that EKG. Depending on where you are, the third step is either moving towards the hospital or calling. And that's challenging to understand. And I think it requires a certain understanding of what happens at the hospital. But I'll give you a rough number, which is that if you're going to be at the hospital in less than 20 minutes, call first. And it takes a while. We can talk about the resources. We should talk about what these calls do and what resources they mobilize. But it takes a while to get everything ready for that patient, which is why the mortality benefit is so clear in that occlusion MI group. So all the things that need to happen have to start happening. They call it parallel processing. While you're moving them to the hospital's getting ready. And no matter how good people are, if somebody walks into the door and we have no idea, either they drove in or it didn't get picked up or you weren't able to pre-notify, we've lost that time and we cannot regain that time. We can't catch back up.
And so for occlusion myocardial infarction, like it comes in, Jen is at the desk. She calls a STEMI alert. Who does that go to, Jen? The STEMI alert. Who gets notified?
That's going to go right to cardiology, to the cath lab. And within a very short period of time, sometimes they're already down there. You've got residents, they're already in the resuscitation bay, and they are looking up the patient. If we have the demos for the patient, I usually will print off an EKG that EMS sent us, hand it right to them. And by the time EMS walks in, if everything works the way, if the stars align, that person has an old EKG, a new EKG, and an assessment done. And they're going, bam, right up to the cath lab. Sometimes they don't even get off the stretcher. And that's when it all comes together. So that time, like you said, Tyler, to gather everybody, to page everybody, to print out old EKGs is so important.
It's also important for hours-wise. Somebody at night, the cath lab is not operating. So somebody needs to physically go in there, a staff member, turn everything on, heat up all the machines. It's kind of like when I'm making muffins, which I make all the time. The first thing I do in the recipe is it tells you what to set the temperature on your oven is. And that's so that when I'm preheating my oven to 400, by the time I'm done making my batter, the oven is at the right temperature for me to put it in.
Yeah,
if my goal is to make muffins, it's preheating, right? If my goal is to make the muffins and I make everything, every once in a while I've forgotten to turn the oven on. And then I'm, right, like, especially if I'm on a time schedule, like the muffins may not happen, right? Because I got to like turn the oven on, and that takes the entire time. So I think if you think about every recipe you've ever followed, it starts with what temperature you turn the oven to. And this is like turning on the oven. It's a whole process. And some places, the cardiologist is literally driving in from their house. Like they are getting out of bed, getting dressed-ish into scrubs, their work pajamas, getting in their car and driving into the hospital to take care of this patient. So like while you are driving the patient to the hospital, the cardiologist is driving in to be able to intervene. There's all of these things that need to happen.
So that's true. It's also true if there's already a patient in the lab. So I've taken care of patients in the emergency department where there's a cardiology team and they are already in the lab. And because of the pre-notification, we're able to get a second team together. But in either case, we're bringing not just the attending interventional cardiologist, but the nurses who help them and everybody else that needs to be there to get all the pieces moving and shaking. And for anybody who hasn't been to one of those cath lab activations, it takes half a dozen people to make that happen. And they all, depending on what's going on with the patient in the hospital, they may all have to come in from home.
Yeah, so let's take one example. Why don't we take an example of trauma, because you have spent the last year trying to jumpstart, and these things that we're talking about are true in Rochester. They're shown nationally, right? Like this data is in multiple studies. The reason for the mortality benefit is because Rochester is not the only place interventional cardiologists are driving in at night. And the more rural and the more community that you are, the more driving there is to do and the less likely that they're going to be in-house. But Tyler took the NAMSP quality improvement course, the year-long last year, and worked on trauma pre-notification specifically. So why don't you tell us a little bit about that? But we could also start with Jen, since Jen takes the phone call, right? So you get this information, and we'll talk about what information you look for. But what happens when you realize that this patient is a trauma alert?
So as soon as we do that, we immediately send out a page that's going to go to the whole trauma team that's on call. It's also going to go to the critical care bay. It's going to go to the triage area, the triage nurses. It's going to go to registration, and all these things get started so that when EMS arrives, they can go directly to the resuscitation bay, and the team will be waiting for them. And depending on what information we get, we may need blood. It'll be there for the patient. And the more time that we get to activate that trauma team, the better.
Yep. And there's other things that happen, like CT holds a spot for that patient. This happens also for, stroke or conditions where somebody needs a time-sensitive CT. When there's a pre-notify, they say, I'm going to hold and make sure that this patient isn't going to need priority before I have a bunch of other patients there. It makes it so that somebody is turning on the lights and warming up an operating room, that an anesthesiologist is notified, because the trauma surgeon might be there, but they need an anesthesiologist to come down. If you think about the complexity of the resources of what kind of system it takes for a critically injured patient to come in, get time-dependent resuscitation, whether or not you are a system that has blood in the field or blood only in the emergency department, to get time-dependent resuscitation there, and then be able to get whatever imaging they need or directly to an operating room and have that warmed up and ready with all the resources. It's kind of amazing that it ever works at all, but it does work. But the key spark that turns that on is a pre-notification with the critical information so that it can happen in a time-dependent way. Tyler?
Yeah, I asked the trauma team what happens because I feel like this is the strongest case for calling ahead, is to understand what happens. And you guys got essentially all of it already. I think the one that's so important for especially our local EMS clinicians to understand is that blood that we talk over and over about, we wish we had blood, we wish we had blood, we know saline's bad for these patients, we don't have blood on the ambulance. That blood is also not sitting in the resuscitation bay unless we've got
a unique thing about Rochester.
Yeah, it is. And, acknowledging there are trauma patients should go to trauma hospitals, very clearly, but God forbid a bleeding patient shows up at one of these smaller hospitals that I've worked in. It takes even longer to get blood ready. Mm-hmm. And so, we'll talk a little bit about other patients you can call for, but it takes time to get blood ready for a patient who's bleeding to death.
Yeah.
And it's not 2 hours, but it's not 30 seconds. And we know how important it is for those patients to get blood. So this is one of those areas where I really love, some of the habits that we have work really well. And this is one of the habits that I think can get adjusted, is we think about all the things we have to do with the trauma patient before we arrive in the hospital. And over and over and over, we prioritize putting an IV in. We have nothing to put in it in our EMS system currently that's going to help the patient. And so getting the hospital aware that the patients coming in will need blood is in this case more important than getting an IV and starting putting saline into them. Far more important. And it was just, I think that's the turning point when I have these conversations where I sort of see providers go oh yeah, I don't have blood, but I can get the patient blood.
Yep. And that doesn't say that en route, you're not putting in access so that they can
Totally.
get hooked up for blood, or even if I'm a pre-hospital EMS system that has blood, nobody has a massive transfusion in the back of their ambulance. So pre-hospital blood programs are really important, and I believe they're going to make significant mortality benefit for patients. But a patient who has gotten pre-hospital blood, who is still bleeding to death, needs massive transfusion, which many trauma centers have blood sitting in the blood fridge in the trauma bay. But nobody has a massive transfusion sitting in a blood fridge in a trauma bay. That requires a separate protocol. So I think that there are things that are local issues, but they're only local issues in that there's some local specificities to them, but this is really an issue for everyone. And regardless, I still need a surgeon to cut somebody open and stop the bleeding.
Yeah.
When they get to the hospital and need to go to the operating room. And so I agree, it's this the order of operations, and sometimes in some places that might change, right? If I have some pre-hospital blood, right, I might prioritize getting an IV and starting the transfusion on the way. But this is both the fun and the challenge of pre-hospital care with limited resources. But the other thing is, let's talk about delegating people to make the call, because one of the things that I find is task saturation. And sometimes people are like, I have to do all the things. And if there's one thing about being a human being is you cannot do all the things. You cannot do all the things well. It's just like I can't run the code and intubate the patient and make sure compressions are ongoing and defibrillation's happening. Like I need to, if I'm going to be honest with myself, I need to cognitively offload and say, you are responsible for making sure these other things happen while I'm doing this thing. What do you think about who can make this call in situations where multiple things can happen? Because like then it can go from, you pick one or two to like you pick three if you can make somebody else do something.
Yeah.
I absolutely agree with that. I have gotten calls, most frequently dispatchers. Lots of dispatchers have called me. They've had limited information, but they've had a crew that's going to be here at our facility in 6 minutes. And they have a GSW to the chest. That's all I need to know. Thank you. They're ETA.
Yeah.
I've gotten calls from volunteer firefighters. I've gotten calls from EMTs driving the ambulance. Not like you should do that, but they are, and you can hear the paramedic yelling to them, 32-year-old female, blah, 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 blah. Whatever way it needs to happen, if you're busy, which you probably are, get somebody to do it for you. Your supervisor, there's usually a supervisor on scene. They can make the call for you. Just get the information to us.
I think this is a place where first responders can be a huge asset. And I totally understand, depending on your system, you may not have that luxury. But in our sort of Metroplex and many of our suburban systems, you're going to at least get a handful of first responders. And they may have less medical training than the transporting crew, but they almost all have enough training that they can communicate that there's a gravely injured or ill patient, basic demographics, and they can call, whichever hospital that patient's going to and tell them that that's what's coming. And so I think that's a great use of that third or fourth or fifth person, even if they're not coming with you. And you can always call an update later, right? Things change. They want a set of vitals. We have more time and information. Great. But we need enough information to Jen so she can get enough information to the trauma team so the things start to happen.
That's a good point, Tyler. And maybe if for crews that are not very close to the hospital, they'll give me a call. Hey, I'm just hopping in the rig. We've still got 20 minutes. This is probably going to be a level, but I'm not sure. They gave me just as much information as they have, and they say, I'll call you back in 10 minutes. Sometimes it turns out to be nothing, but sometimes it turns out to be a lot worse than they imagined it would be. And just to give us a heads up is great.
So we're kind of dancing around the information that should be included. When it's a gunshot wound to the chest, it's not too complicated. A gunshot wound to the chest gets the same level of activation, no matter if their blood pressure is 80/40 or 100/60, or they arrest as they go through the door. It's the same team that meets all three of those patients. But I think it is valuable to go through the framework by which that information should be provided. It's a procedure. So just like when I'm going to start an IV, I'm always going to start by identifying a site, putting a tourniquet on the arm, and wiping off the skin. I'm going to start it off the same way every single time. I can have a little bit of variability, but there's still the essential elements of putting in the IV. A pre-notification is a procedure that has key essential elements that should be followed as a procedure to make it more effective, because I might have ineffective habits in doing procedures like IVs and intubation that make me ineffective at doing those things, and my patient unlikely to benefit when I do that. And I think pre-notification is the exact same. If I'm ineffective at pre-notification and I don't give people the information they need in the way they need it, it's not going to be a very effective procedure. So what are the frameworks that are out there? And what would you recommend as the framework by which people should give the information and practice giving that information before they do it, just like they practice doing procedures before they did them on real humans?
So when I think about what needs to be communicated to the hospital, I want to use the same framework every time, so it's easy and I have that same flow every time. We've done a fair amount of practice with the MIST framework, or sometimes has been upgraded to the DMIST framework. And so let's use that as an example of how we would talk about one of these trauma patients. So D's demographics, and I think it's important for the hospital to hear who you are, sometimes what level of care you have. So we're not asking you to do stuff or assuming you've done stuff that you can or can't do. And then it's nice to have the patient demographics. There are some groups where it really matters, like the cardiac patients. If it's easy to get us that, or if it's important, do that. But we don't need that every time. The demographic we do need every time is whether you think they're probably more or less than 16, because those are different teams. And in trauma specifically, it's a different set of surgeons. And so if you have a 14-year-old trauma or a 40-year-old trauma, that will change what we do. So D's demographics, and specifically, are they more or less than 16 years old? M is for mechanism. So what happened to them? I think sometimes the struggle we get into is you can see the stuff in front of you, and we just assume that like everybody else knows that. So I try to put myself in the framework of the person who's taking the call. They don't know, oh yeah, there's an obvious gaping hole in the middle of the chest. So some mechanism, we don't need a lot of details. Jen will talk more about what is and isn't useful, but was there a gunshot? Was there a stab wound? Or was this blunt trauma? And what part of the body did it happen to? And then injuries or illness. So obvious things you found. We don't need the bruises. We don't need the scrapes. If we already have enough information that they're gravely injured, we don't necessarily need every deformity, but it is super important, especially that core stuff that's going to activate a trauma team. And then signs and symptoms, essentially we're looking for what is the status of their organ systems. So what's their mental status? What's their sort of CNS system doing? What's their cardiopulmonary system doing? So what's their blood pressure? What's their heart rate? We'll figure out, everybody's thinking about shock index now, right? Is the heart rate higher than the systolic blood pressure?
So vital signs.
And then, and then so the reason I add on to that organ system status is we do want to know 22 and struggling to breathe. 22, the oxygen's 94, but that's with BVM and 100% oxygen. And they're really not making any respiratory effort on their own. Like there's a little bit more that we need, but not a lot. And then the big one for mental status, this is a nice change, I think, is that we don't need the whole GCS anymore, but the motor component, which is the easiest one. Basically, can the patient follow commands? Or can they no longer follow commands because they have some insult to their central nervous system? And then T is treatments, and it really just matters the big stuff. Again, we know you guys are doing tons of work. We know the hospital's overwhelmed most of the time. To keep these concise, it's life-saving interventions, like Jen said.
Yeah, so give an example of life-saving interventions.
If you put a tourniquet on because you believe that patient was bleeding to death, we need to know that.
Yeah.
If you're ventilating the patient with a bag valve mask because they cannot breathe adequately on their own, we need to know that.
I think if it falls under XABC, something that you would do during the primary survey on a trauma patient, that's what we need to know about.
That's a great
can let us know about the 50 mics of fentanyl when you get to the ED.
Absolutely. So I'm thinking about the MIST format and mechanism. You can say high-speed MVA, but then you tell me with ejection or with prolonged extrication. Things like that are really important to include with that mechanism because it can make a huge difference. Ejection, hands down. Self-extricate, very, very important.
So we just gave an example of trauma, but Jen's answering the phone for every single patient, every single respiratory distress patient, every single stroke, every single trauma, right? And so when you think about parallel processing, my understanding, Jen, is when you're answering that and I call and I say, this is a trauma alert, you are already, as you're on the phone, opening up the page to the trauma team and typing in the information versus if I say, this is Maya with Gates Ambulance, I'm calling in a stroke alert, you are opening up the paging system to the neurology team and making that page. And so when the parallel processing goes down to the micro level of like what is actually happening at that desk level of who's getting the information. So, and as somebody who was once guilty of going through the entire story and they're like, and what's your ETA? And I was like, what's our ETA? And they're like, we are 2 minutes out. I was like, oh man. Right. And I went through the whole story. I always tell people I'd say, this is my address at calling with Gates Ambulance. I'm calling in a trauma alert. Our ETA is 8 minutes out. I have a 45-year-old male high-speed MVC. He was ejected off his motorcycle on the highway. He has an unstable pelvis, a bunch of thoracic trauma. His heart rate is 120. His systolic blood pressure is 90. His respiratory rate is 24 with effort. Our SpO2 is, 97% with a non-rebreather. And he is only intermittently following commands. Treatment is I'm working on IV. I don't have that. And I've placed a pelvic binder. The end. Right. And so Jen takes that information as like trauma criteria, check. I'm not asking anybody anything. I'm not having a conversation before I send this out. They are 8 minutes out, which is just barely enough time to get all the stuff activated to have this person. We're going to pull somebody out of a trauma bay and get ready and have a plan. And so somebody knows they have a high mechanism blunt trauma patient with a likely unstable pelvis and potential need for chest tubes and likely a TBI who might need advanced airway management, doesn't quite need it just yet. That is the information that is being conveyed. And that was a little bumpy when I did it, but I could do that under stress. And the reason I could do that under stress is I've practiced that framework lots and lots and lots of times, right? And I didn't say like, oh, he also has some road rash on his right butt cheek. Like, who cares? Like, nobody cares. Nobody cares about the road rash in the bike drinks or the laceration above the left eyebrow. Like, nobody is considering, they want to know the severity of the TBI, which is the follow the commands, not like whether or not there's an abrasion on the nose.
Absolutely. And I had a coworker once say to me that I worked alongside, said, lead with the punchline. So yes, obviously, hey, it's Maya. I'm calling from Gates. I'm 8 minutes out. Give me the punchline. What are you doing? Is this patient getting CPR? Are they being bagged? Were they shot? Where were they shot? What is bothering you? What is bothering that patient the most? After I know when you're going to get here, I'm going to write all those things down that you're telling me. And when the doc walks by, I'm going to say, hey, come over here and look at this. And they're going to look at what I'm writing. And then someone else is going to come over. And next thing you know, all these things are in place as I'm getting off the phone. Very important.
Yep. Because the processing starts the moment the phone is answered. The same is true,
Absolutely.
For example, for stroke, right? So you're already, or if you think about stroke, the way that sometimes people feel unsure, right? Like, this is a maybe stroke alert. And so I can say like, this is Maya with Gates Ambulance and I'm 18 minutes out and I'm calling for a potential stroke alert. I have a 86-year-old female. We responded to a fall. And then I can give the clinical exam and history and they can make that decision. But you're already pulling up and you're reminding me to make sure that I cover the last known well, I cover anticoagulants, that I make sure that I've checked a blood sugar and that all those data, because you have a form, that all those data points in the moment of stress, I might forget because I'm doing other things. There's a checklist on the other end that is making sure that I'm giving the right information for the condition that I'm interested in.
Absolutely. Yeah. I have a checklist that I just run down. This last known well, all the stuff anticoagulated, and it flows. And there are some providers out there who give me great reports and I don't have to say a thing. And I say, great,
that's the
see you in
ideal.
5.
Right?
I love it. Yeah.
That's the ideal.
You can also, I think, use that colleague at the comm desk or whoever's answering that phone where you're calling as a resource. So to Maya's point earlier about there's different kinds of patients that need, certain amounts of our attention or different priorities. Sometimes I might call in and say, hey, it's LeMay, I'm coming in with whoever, 8 minutes out with a gunshot wound to the chest. I know that that's all they need. I'm confident that that's a trauma alert. And now we can both go back to doing other things. There might be other times where I call in and I say, hey, to the patient you described earlier, Jen, hey, it's LeMay. I'm calling in. I got this weird EKG and I'm really not sure. I want somebody else to look at it. It's totally fine to express uncertainty. In fact, it's important to express uncertainty. And you can use that other resource because you're busy. And it's not always easy to be the only brain in the back of the box with the patient. Sometimes you want to run that by somebody else.
So just to review what we've done, we went through why is pre-notification so important and why it might be one of the singular most important interventions that we do for a patient. How do we prioritize that clinical intervention amongst others? And really, that's something that people need to think about within the context of care and really think about it kind of ahead of time in all of these different scenarios. And then what are some of the key elements of providing an effective hospital pre-notification? And I'm going to say that's either when you're picking up the phone and talking to somebody like Jen, who's answering the phone, or you're sending an electronic notification in something like Pulsera, or some places use Triage, or any of these where there's a chat type notification with information. It's the same information actually that goes in both, and the same principles actually apply regardless. Given that we've done all that, I'd like to close, because all of that is very concrete, with if you had one piece of advice or like one ask for the people who are listening who are practicing EMS clinicians regarding hospital pre-notification, or a little clinical pearl or a tidbit or whatever you would like it to be, what do you want to leave them with?
If you're questioning whether you should call ahead, you should call ahead.
I like it.
Yeah. I'm always thinking about what is the next thing that this patient in front of me needs. Sometimes that's something I'm going to do. Sometimes that's a phone call or a notification to the people who are going to take care of that patient next. And so thinking about what's time dependent, sometimes everything that's time dependent gets done on scene. And sometimes the most time dependent thing at the moment is moving that patient towards the hospital. Sometimes it's calling the hospital so that those wheels can start turning, regardless of if you're en route yet or not.
If I had to give one thought, it's parallel processing starts immediately. And the way that we decrease time to intervention is that we make more time by making it run simultaneously. We can do literal magic in EMS, which is to make it so that those periods of time overlap with each other. So thank you to all the listeners. Thank you very much to both Tyler and Jen. And Jen, we'll miss you in EMS, but we know you're never far away.
No, never far away.
Can never leave completely. We know it.
No. Have a good one, everybody.
Thanks, gang.
Thank you.